There's always a period of reorganization. Of course, when new leadership comes on, they identify new priorities. They typically issue a lot of RFIs or requests for information to gather feedback from stakeholders. And we're really already experiencing those things now.
I mean, some of the impacts, in addition to staffing, are coming through changes or directives from the executive orders. So I think that is having an impact, and maybe that is, to the extent that we're seeing it now, maybe that's a difference between previous administration turnovers and transitions versus now, is the amount of executive orders and some of the directives.
Welcome to the Move to Value podcast, powered by Chess Health Solutions. In this episode, we're joined by Jennifer Houlihan, Vice President, and Jennifer Gasperini, Director of Policy from Advocate Health's Population Health Team. Together, we unpack the implications of the recent administration change, explore what new leadership at CMS could mean for value-based care, and hear their perspectives on the legislative priorities they hope to see take shape. Jennifer Houlihan, Jennifer Gasperini, welcome to the Move to Value podcast.
Thanks for having us.
Happy to be here.
So you both just attended the NAACOS conference. Can you tell us what are some of the hot topics that folks were talking about?
I can get us started. I think it's always great to see colleagues at the NAACOS conference, and was also great to see Kim Brandt, who is the Deputy Administrator and COO at CMS, come and share some of Dr. Oz's priorities for CMS. And I think a lot of those priorities align really well with value-based care. So they really spoke a lot about tackling fraud and abuse. And as you know, ACOs are really the early identifiers of fraud. And so really was pleased to see them talking about that. And also using technology and better data really for beneficiaries and providers to advance care. And I think ACOs obviously are very focused on that goal as well. Jennifer, do you have anything else to add there?
Yeah, in addition, there were some really good sessions on the new team model, the transferring episode accountability model, as well as a guide, and a lot of thoughtful conversation around how to integrate these models into the ACO and a clearer path for outcomes there. So I think there was great discussion, and got to give kudos to Jennifer. She was part of a really well-attended and fantastic panel on how ACOs are adapting ECQMs and MIPS-CQMs and some of the kind of demands and multiple issues that are impacting ACOs on how to do all payer adjustments, leveraging some of these reporter requirements. So a lot of really timely topics. And I think then the kind of final was specialty care integration, I think continued to be a recurring topic, that we need to think more deeply about that and how those get nested within cost. So hopefully we'll see more about that in the future.
There is new leadership in place at HHS, CMS, and CMMI. What does NAACOS think this might signal for the future of value-based care?
Here, I can jump in on that one first. So I think, looking at Abe Sutton, as Jennifer mentioned, Kim Brandt was there from CMS, but we've also seen with Abe Sutton's appointment, who's been a strong supporter of value-based care, I think the mood was mostly positive, that there has been sort of a lot of statements, whether it's in some of the confirmation hearings or direct statements, that value-based care and the need to achieve savings is one of the priorities. I think there's going to be some different thinking about more aggressive requirements for more savings. And as we've seen already, some of the model review that's already taking place, the ability to kind of end models early if they're not achieving the outcomes and the savings. So I think the mood in general is value is still a strong part of CMS and CMMI's agenda. Just the way some of the models will shape up and some of the strategic priorities, I think we're still waiting to see what that looks like. And Jennifer, I don't know if you have more to add on that.
Yeah, ditto on all those points. And of course, the new leadership is very focused on MAHA, or Making America Healthy Again. And I think value really fits in that lens. And so hopefully we'll see more focus on prevention and wellness, and maybe even some new models that are introducing new concepts around prevention and wellness as well, hopefully. But we do expect to see more from the new leadership team at CMMI on their strategy in the coming months, and that will be really telling, I think, in terms of what their spin on value and their focus will really be.
Yeah, and I'll just tackle them. I mean, one of the first signals we saw was in the 2026 proposed inpatient rule, and the team model is remaining as a mandatory model. And so I think there are some early signals, but as Jennifer said, we're really waiting for that strategic refresh, and then more, really, frankly, announcements on what the future model changes will be.
Interesting. So my next question is a bit duplicative, but I'd like to know what stands out to you about the new head of CMMI, and how do you see his vision shaping programs like ACO REACH?
Yeah, I think, like you said, I'll be a little repetitive here, but I think, well, Abe Sutton, does have experience in value models, so that is very helpful, and has experience working in the first Trump administration. But I think his knowledge of value-based care will help shape the new strategy at CMMI and the agenda at CMMI, and tying that work obviously back to MAHA goals is something that we really expect.
Yeah, I mean, you asked specifically about ACO REACH, and I think we've been hearing lots of rumors. We've heard everything from could ACO REACH be extended? Will it be replaced by something like a revised geo-contracting model? I think there's a lot of what-if scenarios right now, so it's hard to say. But as Jennifer said, Abe Sutton does have a lot of experience. He was the architect of some of the kidney care models. And so I think that's where we're wanting to also see what's next for full risk models, but again, also with an eye towards how are we thinking about specialty integration in some of these full risk models. And so I think there might be some good alignment opportunity there as well.
So historically, how has leadership turnover at HHS impacted innovation models and payment reform initiatives?
Yeah, I think so. The impact has been pretty minimal in the past. I do think we'll have a lot of opportunities to share input on future direction and maybe what we feel hasn't been working, especially in the vein of regulatory relief. That's an area they've been really focused on initially. But, obviously we are losing some staff that has a lot of institutional knowledge. And so I think time will tell in terms of what the true impact is on the programs.
Yeah, because there's definitely been a wave of layoffs across the healthcare policy space. And so how are these reductions in force impacting value-based care programs, especially ACO REACH? That's one thing that's come up as we've been out having conversations with folks with boots on the ground, and how that's going to be impacted. Do you have any thoughts about that?
I think for ACO REACH, I'm not as directly involved with it, and I know Jennifer is more, so maybe can speak more directly, but I think some of the staff is definitely still there, and they're trying their best to follow new leadership direction, executive order implementation. And so I think there was some pause in communications early on, but I don't know, Jennifer, from your standpoint, if that seems to have kind of resolved and it's business as usual. Of course, again, waiting for any, that model I suspect is under review, like all the other models have been under review, and we could expect to see more changes.
Yeah, absolutely. And, like MSSP, they have lost some staff with a lot of institutional knowledge. And so I think there will be a transition period where they hire up and hopefully get some new smart folks into those roles. They've also done, some pulling back of the ACO coordinator positions in an effort to centralize. So most of those positions were in the regional offices previously, and we're seeing CMS move to a more central approach, and therefore we've lost a number of ACO coordinators. And so for MSSP and ACO REACH. But as Jennifer mentioned, I think we're starting to see things level back out, and I hope to see some return to normal programming.
So moving on, what do you see as a major driver, particularly in MA and MCR, from a policy and financial standpoint?
Yeah, so I mean, MA, I think is one of those hot policy topic areas where we're watching. We know some of the new policy leadership within CMS has a lot of experience and thinking around how MA should evolve. And this administration is also considered to be very MA friendly. But that being said, there have been some signals, such as Dr. Oz mentioning in his confirmation hearing, that upcoding is a key factor in costs. And we know that MedPAC, their latest report shows that MA enrollees spend more than traditional Medicare. And then, of course, we can't forget denials and some of the big concerns that we're seeing across health systems and downcoding and denying, both on an inpatient and ED perspective. So there's a lot of swirling, I think, policy within that MA space. And that's where we're trying to understand, even within the new rulemaking, there were a lot of pieces deferred. So what will this mean for the future of some of CMS or CMMI models? Will we see more alignment between traditional Medicare and Medicare Advantage? Will we see some significant changes around some of the coding intensity, benchmarking, risk capture methodologies? I think all of those seem to be up for conversation. And again, I think time will tell of how the administration continues to move forward on that. We do know for some of the policy briefs out there through groups like Project 2025 and Paragon, who've written extensively on MA, that there are a lot of proposals to strengthen MA's presence in the healthcare landscape. So at this point, what we're doing is kind of watching and waiting and looking for signals such as, the recently reduced rules and what we might expect. Jennifer, anything to add on your end?
I think just that, Jennifer mentioned earlier the geographic direct contracting model that we saw under the first Trump administration, which is very MA friendly. And we do expect to see a resurgence of that type of thinking or that type of model in this administration as well.
Well, as we're all aware, there's been quite a flux in the economy recently. Do you think the current economic pressures are reshaping how health systems think about pop health investment?
We're still in a time of, I hate to use the phrase two canoes, but given all the progress we've made, we're still, in my opinion, very much in a fee-for-service world with fee-for-value, but fee-for-service still very much dominating the reimbursement space. And I think we're also just in general in a time of, tremendous change and transition with so many other policy levers outside of pop health impacting where healthcare systems may be going, site neutral, changes on the horizon potentially around Medicaid space. So I think in one hand, pop health is viewed still as the future forward of how do you get away from fee-for-service. But on the other hand, we're still sort of a component in a very large health system that has a large footprint of hospitals, and we have to balance between the revenue models.
So looking back at ACO REACH under the current administration's first term, what progress was made, and what programs or policies do you expect will be continued or changed under this second term?
That's a great question. So, I mentioned that the first Trump administration originally released that GO direct contracting model. It came under a lot of scrutiny and was later canceled, under the Biden administration as a result of that scrutiny. And I think there was a lot of pushback I think it's likely we'll see a return of a similar model under this administration. What that looks like exactly, I do not know. I think there's a lot of questions unanswered right now around that. But I do expect, I think a lot of others expect a return of a similar type of model under this administration.
Well, can you tell us about the legislative efforts to reinstate and extend bonuses for providers participating in risk-based models? And they view these incentives as essential for sustaining and expanding value-based care. What is the latest? Do you think this push has any momentum?
It was definitely one of our policy priorities, and there was, I guess, was it the end of last year, Jennifer, a bill introduced to extend the APM bonus. But the latest that we were hearing, again, this could now be outdated information, was that it is not currently part of reconciliation, but that it may be brought back up in the fall. Jennifer, I don't know if you've had any latest updates. So it's still out there as a priority, but overall not seeing a lot of traction right now.
Yeah, and I know it was devastating to see that bipartisan agreement come together end of last year and then really fall apart at the last moment and not get passed. So the bonus has expired as of today, but it is still a really big priority for Advocate and for a lot of stakeholder groups like NAACOS and others. I think there are spending pressures in Congress that are really going to make it difficult given the current environment. But I do think Congress is still committed to tackling the issue of broader reform of incentives and payments for value. Even the MIPS program is something that has been highly criticized over the years as not living up to its intended goals and, having a lot of regulatory burdens associated with it. So I think there is appetite for broader reforms, but the timing for this year in particular, I think are going to be difficult. So, but I am hopeful that maybe in the coming years, we'll see a turn to attention on a broader reform.
Well, back in January, bipartisan legislation titled the Healthcare Efficiency Through Flexibility Act was introduced in the U.S. House. And this bill proposes delaying the mandatory ECQM reporting requirement for ACOs until January 1, 2030. What's your take on this delay? Is it necessary breathing room or a missed opportunity?
Yeah, that's a great question. I know Advocate has committed a lot of resources to making ECQMs a reality. It takes an enormous amount of time and money and work, even ongoing work to do this. And in talking to other ACOs, I think there are a lot of ACOs that do need more time. And what dawned on me at the NAACOS meeting is that I think, frankly, we're still debating the details because there were many very smart people at NAACOS and some discussion and differing opinions about how can you report ECQMs, the technical details of, what the file has to be, for example, and what constitutes data completeness. So as some examples, I think this really signals there's still some confusion out there and lack of clarity around these requirements. So I think having a backup or more time is not a bad thing for anyone, given the uncertainty. However, I think it's important that we don't lose momentum since so many people, including Advocate, have already invested a lot into making this transition. And I do think looking to a less manual, more digital quality reporting process is a good goal for the future. And we want to continue to make those investments. So it's about getting the details right, making sure there are reasonable expectations, so exclusions that allow for really kind of common sense exclusions that allow for things that we can expect to happen during the year, like transitioning to a new EMR or other challenges that do pop up realistically, to not really take down your whole effort.
Well, is quality reporting broken? I mean, what's working, what's not? How do we fix it?
So I can start here. I think so. Quality reporting is extremely costly and time intensive, even when you're reporting ECQMs. So I think there are a couple of camps of thinking on this topic, though. Some think we should move to a REACH approach or model where ACOs are only evaluated on a small number of mostly administrative claims measures. Those don't involve any reporting. But others think that wouldn't accurately measure the quality of care that we're providing to patients. So I think yes and no. Is it broken? I think it can be improved for sure. How to fix it, I don't have those answers, but I do want to note that the proposed 2026 inpatient rule did include an RFI on this topic. And so I think that signals that CMS is open to hearing what's working now, what some of these challenges are, and where we think we want to go in terms of the future. And I'm really interested to see what the new leadership at CMS is thinking on this topic.
Well, we've come up against time, but there's still so many unanswered questions that I have for the both of you. Would you be willing to stick around for a few more minutes so that we can continue this conversation?
Sure.
Yeah.
This has been the Move to Value podcast, where we explore the people, ideas, and innovations driving value-based care forward. We hope you enjoyed this episode. Whether you're on the front lines of transformation or just getting started on the path to value, this is your place to learn, connect, and move the conversation forward. To explore this and other episodes, visit movetovaluepodcast.com for show notes and additional resources. If you'd like to stay informed about the latest in value-based care, be sure to subscribe to the podcast on your favorite platform or sign up for email updates on our website. And if you found this episode helpful, please consider sharing it with your network and leave a rating or review. It really helps others find the show. Thanks for listening.